everybody. I'm really thankful to you for this wonderful event. I don't know why I can't start my video. Can someone? Okay, now. Okay, thank you very much. Thank you very much. Let's start. I'm Blerina Saraci. I'm from Tirana, Albania. I represent the University of Medicine here in my country. And I want to show you this topic that I think it's important for the pediatrician community because the multiparametric ultrasound is now present in the adult community, adult population patient, but in pediatric it's a little bit more difficult because of cutoffs and specifics that pediatric patients have. So for this reason, I think it's important for all pediatric population, but more for small countries like Albania needs to have this opportunity to speak about these topics. Thank you very much. Okay. We are going to talk about artificial intelligence in pediatric radiology, multiparametric ultrasound with their component like elastography, contrast enhanced ultrasound, and UGAP with fatigue quantification in pediatric liver patients. And the future of pediatry is going to be in this field or not? Artificial intelligence in medical imaging has rapidly expanded, but in pediatric population, it is a little bit more difficult. Of the more than 200 artificial intelligence software as a medical device cleared by FDA, only 6, around 3% of this, I indicated that they are intended for pediatric use. So only a very small part of all the softwares. There are no computer-aided diagnosis radiological products authorized that can be used for pediatric users. Pediatric and adult radiology differ well, particularly with represent of age-related physical anatomy and diagnosis and differences in imaging acquisition parameters, because we have different acquisition parameters in different ages group to protect them from over radiation exposure or other conditions that cannot perform in the same way in different patients. Pediatric imaging acquired with significantly reduced CT radiation doses, as recommended for children and examined gently, is a tool that make difficulties to products from IE to be performed in pediatric population. Often have higher inherent imaging noisy levels than may not be produced. IE algorithms trained on higher doses, adult imaging, are not compliant with these examinations by the pediatric population. Artificial intelligence tool trained exclusively on adult patients. Data may not perform the same way in the pediatric population. This process takes into account subpopulations on the basis of patients' age and specifics of children's anatomy and physiological changes with age. Children's healthcare, different patient size. So we have different patient size in different groups. And so we have subgroups, like I said before, different appearances of multiple organs, as well as the various ages of as well as variations in patterns of injury and diseases can present challenges for pediatric radiologists. What this means? This means that different groups have different pathologies that prevalent, firstly. And secondly, we have the difference of appearance of organs in different ages. For example, the thymus is not the same in different ages group. Okay, this can be learned to the machine, but it's a little bit difficult to be performed with the software that we have now for adult one. Changes in the appearances. bone marrow cell, tissue size structure, as I say, changes in cerebral metabolism and organs perfusion and functionality immaturity. Also have implicates from artificial intelligence development and subsequently clinical performance. Variations in vascular lumen size, cardiac output, and circulation time, as well as organ perfusion states require different doses, concentration, and administration technique of intravascular contrast agent, contrast enhancement agent, to protect and to produce the required tissue contrast enhancement. Challenges in acquisition and added challenges of imaging of pediatric patients is the frequent requirement of sedation or anesthesia. That is a challenge for the medical doctors that perform this examination, which also has implication for observed tissues perfusion. Biometrics such as the respiratory rate and cardiac output require considerations of age and are commonly used for respiratory and cardiac gating in imaging acquisition and acquired imaging interpretation. It is widely recognized that children are more susceptible than adults to similar doses of ionizing radiation. Specifically, young children are more radiosensitive than adults, leading to higher cancer risk per unit doses of ionizing radiation. In this field, we have to protect them and to use lower doses as possible. And this is a challenge for the machine to recognize examinations performed with different doses and different parameters. Here is a photo that I took by my own in Tartu in one of meeting there, meeting about pediatric radiology. And in this photo, I really love this photo. In this photo is a young boy and an older man together in the same vowel for the health community, but with a lot of differences in their bodies. So this is the icon that present better what I'm saying till now about challenges, but challenges in pediatric patients, but the same necessities that have the adult ones. Another point that we have to take in mind, not even the challenge about the differences, is the ethical consideration that in pediatric patient is a little bit more sensitive. In pediatric cases in which parental consent was obtained during standard of care treatment, additional issues arise. Should patient be able to opt out of continued inclusion in a database after reaching legal age, because the consent is taken by parents in the period they are infants or pediatric community, but in the time that they become adult, is possible for them to go take out their information and to go out of these databases? Is one question. Also very variety of statuses require the retention of pediatric imaging until the child research adulthood. Should imaging examinations that were previously interpreted without artificial intelligence be realized when artificial intelligence become available? So we can we use databases from the past to teach the machines now? This is another question, because we have the consent for the period there was a patient, but now they're adults. We have to have their permissions, for example. And also the transparency on the population and the changes on the demography impact very well the situation. Recommendations including a statement recognizing authorization specifically for uses, including a description of the evidence that does or does not support use in children, and the lack of such evidences. All FDA authorization IE devices. IE in pediatric radiology. Overview of current IE programs. We have programs all around the world about X-ray. The most uses are for chest X-ray, hand bone age, bone fractures. These are the top IE programs used for pediatric population by X-ray examination. But artificial intelligence also impact ultrasound. In multiparametric ultrasound, we use artificial intelligence in elastography, CEUS, and UGAP. In conclusion, the few available comparative pediatric and adult performance studies showed lack of strength for generalizability to the pediatric population patient. Multiparametric ultrasound in pediatric radiology, elastography. Elastography is an advanced imaging modality used to assess the mechanical properties of tissues, particularly tissue stiffness. Increased tissue stiffness detected through elastography may be indicative of pathological changes, including fibrosis, inflammation, or malignance. This non-invasive technique is commonly utilized in evaluation of liver disease, as well as in the assessment of other organs such as the breast, the thyroid, eye tools used to detect adults in adults has a specific in pediatric patient around 37%. Also, one of third. In the pictures on the left, you show some of images about elastography in the thyroid, elastography of the liver with the confidence map and UGAP, and also some the picture about the mechanism of elastography waves. Okay. Multiple parametric ultrasound in pediatric radiology, our experience in Albania. This is a paper, poster presentation in the meeting that Eurozone 2024 was in Nepal, and we represent a paper, a patient with focal nodular hyperplasia, 12 years old, that come at our institution with epigastric pain. We perform the ultrasound and we show mass, oval mass, and the patient was diagnosed with focal nodular hyperplasia. We use ultrasound with multiparametric protocol to examine the stiffness of the tissue, and we show that the focal nodular hyperplasia was harder than the surrounded tissue of the liver. This is another presentation that we take in the same meeting, and we present our study. We have around 30 young patients, pediatric patients with hepatitis C, and we perform a standard protocol for the stiffness of the liver, to evaluate the stiffness of the liver. The age group was from 4 to 15 years old, and the charter represents the stages of fibrosis that we find. Usually we find around F0 to F1, that is the normal range, and fewer of them have the F2 grade of fibrosis. No one have a grade 3 or grade 4, virtually. Here we have another slide. Petit quantification. Petit quantification is another tool that we have to take in mind. It's a numeric vowel of the fatty liver, so we can have a quantitative vowel of fatty liver, not only the qualitative overview of the standard ultrasound examination. Quantification of hepatic fat is traditionally performed through liver biopsy. However, this method is invasive and subject to sampling errors. Other modalities, including standard ultrasound, MRI, and multiparametric ultrasound, later allows for a quantitative assessment of hepatic fatty content. This procedure requires little to no special preparation, is not invasive, and is quite easy to perform for all the population and for children more. The protocol of and the cutoff values for this product procedure in pediatric population is still not very well confirmed, so it's a challenge as subjects of many studies in the field that we can have a lot of research and to conclude in a better cutoff for this population. Here is a schematic view of what we are saying. Multiparametric UGAP in pediatric radiology, CEUS, is another important tool. In the picture, you can see from the microbubble to the imaging how we can perform. Since the mid-19th, ultrasound contrast enhancement agent have been used off-label in pediatric imaging, primarily in Europe for contrast enhancement void urosonography, CEUS, to detect vesicular reflux. A major advancement occurred in 2016 when the FDA approved the use of contrast enhancement ultrasound in children aged from 0 to 17 years old for both intravenous and intravisceral application, followed by similar pediatric approval in Europe and China. This is the device that we use to inject the contrast. Is 3 ways. Multiparametric UGAP in pediatric radiology, CEUS procedure. Advantages: safe for children with renal impairment or nephrotoxicity medication. Microbubbles visualize both arterial and venous circulation. No ionizing radiation, no soft tissue deposit. Portable exam ideal for critical ill patients. Easily reparable and more cost-effective than CT MRI. No need for renal or liver function tests. Minimize blood draws, especially important for neonates. Shortest waiting time compared to CT and MRI. Disadvantages: time consuming for radiologists. Most ultrasound software is currently suboptimal. Clinical relevant quantification need more widely available advanced software. CEUS requires lower mechanical index. High mechanical index can rupture the microbubble and reduce imaging quality. Optimal imaging is achieved about 0.1. CEUS software use low mechanical index, low thermal index, low upper output, higher frame rates, harmonic imaging, and pulse inversion. On-label for liver and kidney, off-label for trauma, lung, brain, pancreas, UGAP tract bowel. Here is a visual map of what is on-label and off-label. Multiple parametric UGAP in pediatric radiology, US conclusions. Here are the conclusions that you can see by your own, because the time is short and we have to be in the end of the representation. The future of pediatric radiology. And thank you very much.